Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
Good afternoon. Oh, that was too loud. Anyway, so hello, my name is Nataliya Marr. I am a genitourinary medical oncologist at UC Irvine, and today I'm going to talk to you about exciting trials from ASCO 2023 in the genitourinary space. And we want to be fair to every disease type, so I picked one abstract from the bladder space, one abstract from the kidney space, and one abstract from the prostate space. And the reason that I picked them is because I do think that these are fairly practice-changing studies that potentially would affect how you practice medicine and oncology. And then I also framed it in the context of a sample patient. So this kind of all becomes real. Okay, so these are my disclosures. And then we're going to go into scenario number one. So scenario number one is your typical 70-year-old patient who presents with 3 episodes of gross hematuria. His kidney function is decent, GFR is 75, and ECOG performance status is 1. He has a CT scan of his abdomen and pelvis that shows asymmetric bladder wall thickening and perivesicular fat stranding, but no obvious adenopathy or metastatic disease. CT chest is also negative for metastatic disease. He has a cystoscopy which shows a tumor inside his bladder, which is involving the right UVJ, and also another tumor at the bladder neck. He has a TURBT, which reveals high-grade urothelial carcinoma invasive into the muscle layer of the bladder. So what would you do next? So I'm going to give you 2 seconds to think about that. Or if someone wants to volunteer, I would be happy to hear it. Okay, so I'm sure that what you're asking yourself is this patient eligible for cystectomy? Because that's kind of the cornerstone gold standard still in the bladder cancer world. And the other question you're asking yourself is this patient eligible for cisplatin? So typically the standard of care in patients who are cystectomy eligible and cisplatin eligible is neoadjuvant chemotherapy with a cisplatin-based regimen followed by radical cystectomy. So benefits of neoadjuvant chemotherapy in this case would be to immediately treat any micrometastatic disease that might be present downstage surgically unresectable or borderline resectable tumors, and also select out patients with aggressive disease who would progress quickly and therefore do not really need a cystectomy. So, so far, we have 2 regimens that are used fairly interchangeably in this space, in the neoadjuvant space. Both are cisplatin-based, but one is dose-dense MVAC, which is a combination of 4 different agents, including cisplatin. And then the second regimen that is commonly used is cisplatin plus gemcitabine. And until very recently, we had no prospective trials comparing both of these regimens. All we had was retrospective data that kind of look at rates of pathologic response between all of these regimens, and that's what we had to go by. So until recently, they were considered fairly interchangeable, and most commonly cisplatin gemcitabine is used simply because it's easier to tolerate. And dose-dense MVAC is more toxic, it's harder to get the patients through it, so it is much more rarely used. So here I listed 2 of the retrospective reviews that were done comparing these 2 regimens. And the holy grail kind of here, the endpoint that we look at is the rate of pathologic complete response, meaning that someone had the neoadjuvant chemotherapy, somebody had the surgery, and then at the time of surgery, there was no tumor remaining. So that's what we want with neoadjuvant chemotherapy. So I'm going to direct your attention to the second retrospective review of over 1,000 patients. And in this particular case, the rates of Pathologic complete response with dose-dense MVAC were about 41%, with cisgem was 24%, and with carbogem, which really should not be used in the neoadjuvant space in bladder cancer, 9.4%. So you see that, they're vastly, vastly different. Also, this retrospective review showed a trend towards overall survival, but this was not statistically significant. So this is all we had in this field until the VESPER trial. So the VESPER trial is our first prospective study, which is randomized phase 3 trial. It's a European study that looks at dose-dense MVAC for 6 cycles versus cisgem for 4 cycles. And we can debate the number of cycles, but it's the regimen that matters. So, wow, this is very pale, but this looks at the 2 arms of the trial. Interestingly, in this trial, they allowed for the chemotherapy to be given both in the neoadjuvant space and in the adjuvant space. But only a vast minority of patients received it in the adjuvant space. Most of the patients received it in the neoadjuvant space. So the adjuvant enrollment was so low that they could not draw any conclusions, so we're not even going to talk about it. We're only going to focus on the neoadjuvant patients. So if you look at, let's see if I can point. There we go, it works. Right here. So if you look at right here, I don't know if you could see that, but this is the clinical T stage at the time of enrollment on the study. And you can see that the vast majority of patients were T2, and then only a tiny amount were T3 and T4 on this study. And I think that's all I want you to see there. So first we have, the study has been going on for a while. The first data point I want you to look at is a 3-year data cutoff for this trial. And this is the 3-year progression-free survival between the two regimens. And you can see that the blue is dose-dense MVAC, the red is the gem-cis, and you can see that these curves are very much diverging, right? So on the left, we have all patients in the study, and then on the right, we have only the neoadjuvant patients. And you can see that in both groups, the blue is higher than the red, which means that the PFS favors dose-dense MVAC. The same is true for time to progression, and then the overall survival estimates. So these were the 3-year numbers, and what was presented at the ASCO 2023 meeting were the final 5-year analysis. And we can see that at 5 years, this pretty much held up. So the 5-year overall survival in the entire study population was 64% with dose-dense MVAC, and 56% with cisgem, with a hazard ratio of 0.77. Disease stability rate at 5 years is 72% with dose-dense MVAC and 59% with cisgem. Hazard ratio is 0.63. And then if you look at the same endpoints with just the neoadjuvant patients, then the numbers were very, very similar, favoring dose-dense MVAC. Also, we do worry about toxicity with dose-dense MVAC versus cisgem. And what the study showed was that in the neoadjuvant chemotherapy group, 60% of patients were able to receive all 6 cycles of dose-dense MVAC versus 84% who were able to receive 4 cycles of cisgem. Also, very similar numbers between the two groups, 91 versus 90%, were able to move on to cystectomy. So even though some patients did not receive the full course of neoadjuvant chemotherapy, practically all of them did have cystectomy, and the numbers were equal between the groups. Also, the main cause of death in the trial was bladder cancer progression in 83% of the patient. And then other causes were cardiovascular events in about 4% of patients, toxicity, 2% of patients, secondary cancers, 2% of patients, other and undocumented composite, about 8.5%. So overall, I think what this is pointing to is that dose-dense MVAC should be the preferred chemotherapy choice for neoadjuvant muscle-invasive bladder cancer patients, and that it works better, and that toxicities are similar, and that dose-dense MVAC does not delay the time to cystectomy or cause patients not to have a cystectomy. So moving on to scenario number 2. So again, a patient example. We have a 56-year-old woman who developed 3 episodes of gross hematuria. CT abdomen pelvis showed a 12-centimeter right renal mass with IVC invasion. And CT chest showed multiple pulmonary metastases and enlarged mediastinal lymph nodes. She had a biopsy of a lung lesion that showed metastatic clear cell renal cell carcinoma. She was started on combination therapy with pembrolizumab and axitinib with iRECIST partial response. The response lasted for about 18 months, and then she developed disease progression. And what would you do as your next step?
Don't use IO. Contact 3.
Oh my gosh, that's great. Thank you, audience participation. I love it. Okay. So this is just a very brief summary of available first-line regimens for metastatic renal cell carcinoma, clear cell subtype. And what I want to show you is that every single one includes immunotherapy. So chances are your patients are getting immunotherapy in the first-line setting. It's also possible with the recent approval of pembrolizumab for high-risk stage 3 disease that your patient may have received immunotherapy in that space. And if they develop disease recurrence, then what do you do? Thank you, CONTACT-03. So CONTACT-03 was a trial that was presented at ASCO, this ASCO meeting this year, which I think was important because one of the questions that we ask ourselves is, can we reuse immunotherapy after failure of immunotherapy? And in some diseases, the answer is yes. In renal cell carcinoma, this is our first trial that really looked at this question. So CONTACT-03 was a randomized phase 3 study of cabozantinib versus cabozantinib plus atezolizumab. The patients they enrolled were a mix. They had both clear cell and non-clear cell histology, but the vast majority were clear cell. And they had to have progressed on a prior checkpoint inhibitor. They did allow 1 to 2 prior lines of therapy and enrolled a total of 522 patients. About 55% of patients in the combination arm and 51% of patients in cabo arm had a checkpoint inhibitor in the first-line setting. And then this was the first data cutoff at about 15 months. So this is just kind of a patient demographic slide on the patients between the 2 groups. They were fairly balanced. This just shows, their sex, ethnicity, their number of prior TKI therapies, their IMDC risk score. So all of the kind of things that we look for RCC. And again, this is just kind of the same thing, a little bit more detail about what these patients received prior to trial enrollment. I do have to point out that this trial did not include a lot of patients in the adjuvant space who received adjuvant pembrolizumab. It was just a fraction of a percent. So this is patients who received checkpoint inhibitor in the metastatic space. So this was the primary endpoint of the trial, which was progression-free survival. And what you can see is that the curves are fairly on top of each other. So there was really no difference between the two groups. Median PFS for the combo was 10.6 months, and then for cabo alone, it was 10.8 months. So very, very similar. The hazard ratio was over 1. And this is our overall survival, and again, you can see that the curves are kind of fairly on top of each other again. And then the median OS for the combo was 25.7 months, and for cabo, not evaluable. So the hazard ratio was pretty close to 1.94. So in the end of things, this was a negative trial. Also looking at some other endpoints, the overall response rate was 41% in both arms, so it was identical. The duration of response was 12.7 months with the combination versus 14.8 months with cabo, so cabo group did a little bit better. And the grade 3 to 4 adverse events were fairly similar between the group. The two groups, but the adverse events leading to treatment withdrawal were 16% with the combination versus 4% with cabo alone. So you can see that that's a huge difference, 16 versus 4% for discontinuation of treatment. So not only was this trial negative in terms of effectiveness, you could also see more adverse events with the combination group with a checkpoint inhibitor. So takeaway point is that unless you have a very compelling reason, you really should not be reusing a checkpoint inhibitor at this point after failure of another checkpoint inhibitor. And there is another trial called Tenevo that is ongoing with a PD-1 inhibitor rather than the PD-L1 inhibitor that was used in this trial, which was one of the criticisms, is that maybe PD-L1 inhibitors work less well for renal cell carcinoma. So we will see. But for now, this is what we have with the CONTACT-03. And then the last one. So this is scenario number 3. So we have a 68-year-old man who developed lower urinary tract symptoms and gradually worsening back pain. CT scan of the abdomen and pelvis showed an enlarged prostate with a large mass invading into the bladder, seminal vesicle and rectum, enlarged iliac lymph nodes, and multiple bony lesions. He had a CT chest that showed additional bony lesions but no pulmonary metastasis. His PSA was over 1,200. He had a prostate biopsy that showed a Gleason 8 adenocarcinoma. He was started on relugolix, which is an ADT choice, plus abiraterone. He achieved a PSA and radiographic response, as well as clinical improvement in his symptoms for 14 months. But then PSA started to rise. What would you do next? So I'm sure you all know what you would do next in your mind. But these are our treatment options. So at this point, this man has developed metastatic castrate-resistant prostate cancer because he has disease progression on ADT with a castrate range, presuming, of testosterone. So this is our laundry list of options for MCRPC. So partly, the choice of what you do next depends on what the patient received in the metastatic hormone-sensitive space. But just to divide these up into classes, we have a couple of novel hormonal therapies, which are up top. We have 3 chemotherapy agents. We have 2 nuclear agents. We have immunotherapy. We have PARP inhibitors. And then the 2 latest kids on the blocks are combinations of a novel hormonal therapy plus a PARP inhibitor. So these 2 FDA approvals came very, very recently this year. So we're going to talk about that a little bit more. So about 10% of primary prostate tumors and about 25% of metastases harbor somatic DDR or DNA damage repair pathway alterations. And then also about 8 to 16% of prostate cancer patients have germline DDR alterations. And then in terms of what these are, I provided you a partial list, but the more famous ones are BRCA1 and 2. There are others as well. And then just to mention this, because this term is sometimes used instead of DDR, there is a term of HRR, or homologous recombination repair, which is a mechanism to restore DNA integrity within the DDR pathway. So sometimes one term is used, sometimes the other term is used. I want you to know both. So in the recent past, we had 2 approvals of PARP inhibitors for prostate cancer. One was olaparib, single agent, based on a PROfound study. And this drug is approved for metastatic castrate-resistant prostate cancer post-progression on 1 novel hormonal therapy. The second is rucaparib, based on Triton-2 study, which received approval for metastatic castrate-resistant prostate cancer post-progression on 1 novel hormonal therapy agent and 1 taxane chemotherapy. So the question is, can we move this up into an earlier setting? Will it work? And can we use it in combination with something else? So these are the 2 studies that recently came up, were resulted. And what we're going to focus on is the TALAPRO-2 study, which was presented at ASCO 2023 with a simultaneous publication in Lancet, and then approval. So first, we're just going to briefly go through PROPEL. So PROPEL was the study of olaparib plus abiraterone combination. It was a phase 3 randomized double-blind study of olaparib and abiraterone versus placebo plus abiraterone. They enrolled patients with first-line mCRPC, allowed prior docetaxel in metastatic hormone-sensitive disease. They enrolled patients, and this is a key point, regardless of HRR status, both positive and negative, but they did check the status at the time of study enrollment. This study enrolled 796 patients, roughly about a third, I guess 28% were HRR positive, 69% were HRR negative, and 2.3%, we don't know what they had, unknown status. And what this study showed was that progression-free survival was favoring the PARP-containing group, but the most benefit was seen in the HRR positive patients, which makes sense. So because of this, this is how the drug got approved. It only got approved as combination for HRR positive patients. And now we're going to focus a little bit on the TALAPRO-2 study, which is what was presented at ASCO 2023. And this trial was very similar to the PROPEL, except they used different drugs. So in this case, they used talazoparib, which is a slightly different PARP, and enzalutamide versus placebo and enzalutamide. The only other difference was that this trial did allow prior docetaxel and abiraterone in the metastatic hormone-sensitive space, which kind of is more reflective of the current standard of care, because docetaxel is hardly used anymore for the MCSPC patients. So this was a little bit more modern in terms of design. And otherwise, it was very similar to the PROPEL study. They enrolled patients regardless of HRR status, but did obtain it at the time of study entry. And they enrolled 805 patients, and this was the first data cutoff at 25 months. So in this case, the median PFS was not reached yet with the talazoparib arm versus 21.9 months in the placebo arm. The hazard ratio was 0.63. They did note that, again, similar to the PROPEL study, the HRR deficient patients benefited significantly more than HRR negative patients. And that's why also this combination was approved only in HRR positive patients. We can't comment yet on the overall survival data. It's immature. And then all the other endpoints of this trial, like objective response rate, PSA response by 50%, time to PSA progression, use of subsequent chemotherapy, all of that favored talazoparib. And they had some quality of life data, which also favored talazoparib. In terms of side effects, grade 3 and 4 treatment-related adverse events were higher with the talazoparib, 71.9% versus 40.6%. Most common significant adverse events were anemia, neutropenia, thrombocytopenia, kind of what you would expect with a PARP, high blood pressure, fatigue, etc. So nothing kind of unexpected. And treatment-related adverse events that led to discontinuation of talazoparib were seen in 19% of patients versus placebo in 12% of patients. And then discontinuation rates of enzalutamide were fairly similar between the two groups. So takeaway from this is that if you have a patient that's HRR positive, we should consider using a combination with a PARP instead of NHT alone. The trade-off might be that you have some more toxicity, but you have to make a judgment call between effectiveness and toxicity. I also wanted to make a point that it's extremely important to test both germline and somatic send both germline and somatic genomic sequencing for locally advanced and metastatic prostate cancer patients. As you can see, you might miss out on this mutation-based line of therapy if you don't check it. And I'm going to give a 2-second plug for my own research project, which is what the QR code represents. So Dr. Kapoor and myself, she's one of our fellows who is wonderful, are looking at how providers feel about metastatic prostate cancer patients and their treatments, as well as patterns of genomic testing in that patient population. This is a really quick survey for providers who take care of prostate cancer patients. It might be med-oncs, rad-oncs, urologists, nurse practitioners, whoever takes care of these patients. Very quick, 5 minutes, and you're going to make a difference. So please take it or find me after this, and I'll give you the QR code.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.